Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of speaking with both Megan Gorman and Marina Frimer. And we're going to talk about the article, Addition of Metronidazole to Standard of Care Perioperative Prophylaxis at the Time of Hysterectomy for Gynecologic Malignancies. Megan is at actually completed her fellowship at Northwell Health in Long Island Jewish Medical Center in Long Island in New York and New Hyde Park, and now is practicing as a new faculty at Thomas Jefferson University Department of Obstetrics and Gynecology at the Division of Gynecologic Oncology in Philadelphia and Pennsylvania. And then Marina, of course, is at Northwell, again, Long Island Jewish Medical Center, at the Division of Gynecologic Oncology there in New Hyde Park, New York. Megan, Marina, thank you so much for accepting our invitation to join us for the podcast. Congratulations on really very great work and a topic that is so relevant to all of us who are practicing in gynecologic oncology, and particularly those who are trying to initiate our surgical site infection prevention bundles, our enhanced recovery programs. So thank you again for accepting to discuss this paper.
Thank you so much for inviting us. We're very excited to talk about this.
Thank you so much.
Well, I'll start with you, Megan. Let's start by discussing how common are surgical site infections in the setting of gynecologic oncology surgery, and what are its implications?
So surgical site infections in gynecologic oncology in the modern era are thankfully relatively uncommon. And we should be clear about what we're categorizing as an SSI, or a surgical site infection. So in other words, it's an infection that's related to an operative procedure that occurs at or near the surgical site within 30 days of surgery. We think about SSIs in three broad categories: superficial incisional infections that involve the skin and the subcutaneous tissue, deep incisional infections that affect the fascia and the muscle, and then organ or deep space infections. Overall, the data shows that there's an SSI rate of roughly 1 to 3% associated with hysterectomies in general. So one study of 350 women who underwent hysterectomies for benign or malignant indications, the incidence of all types of SSIs was about 2.1%. And that study did show a higher risk of infection for those who had an open surgery versus laparoscopy. Specific to GYN oncology, one study from 2014, that was a large retrospective cohort study, reported an incidence of up to 5.4% of SSIs after hysterectomy for gynecologic cancers, with the most common site of infection being superficial in that group. Among GYN cancers, SSIs are most commonly found in patients with endometrial malignancies, followed in incidence by ovarian and then cervical cancers. And as you mentioned, there are significant implications for infections. The morbidity and mortality of SSIs in these patients includes things like increased hospital stays, increased use of antibiotics, possible increased antibiotic resistance, slower post-op recovery, and significantly delays in adjuvant therapy.
Yeah, so thank you for that great introduction. And, certainly for our listeners, highlighting and stressing the importance of surgical site infections for us, it is an indicator of the quality of care of our healthcare system, and particularly for our international listeners. So this is something that we, as physicians and those caring for patients, put a great deal of emphasis to decrease surgical site infection. So I'll turn over to Marina now. What are some of the strategies that we may use in order to prevent and target surgical site infections?
So preoperative risk modification is absolutely necessary to target the surgical site infection rates. And in our patients who require cancer surgery in the next few weeks, possibly, risk modification becomes really difficult. Modifiable risk factors do include smoking and glucose stabilization, hemoglobin A1C changes being less than 9. However, obesity, which significantly increases risk of surgical site infection, and diabetes may be very difficult to modify preoperatively. So preoperative antibiotics have been shown to significantly decrease these risk factors and decrease risk of infection. And recovery bundles such as the ERAS protocols, now widely used across health systems, are also used to decrease these risks.
Excellent. Now, Megan, specifically, what was the rationale for this study? Like, why did you think it was important to conduct this study to address this particular question?
So this study was really born out of a quality review that we were doing within our institution, in which we noted that there were higher postoperative infection rates overall. And so that kind of started as a smaller quality improvement project to introduce flagella into preoperative prophylaxis. And that smaller QI project showed that there was an improvement in infection rates with the addition of flagella. And so based on that data and kind of the recognition that we were on the verge of a larger institutional change with the introduction of ERAS, we wanted to kind of evaluate this addition with a larger cohort of women.
Excellent. Marina, I'll turn to you with regards to the study design. Tell us a little bit about the inclusion criteria, and then also what was the primary endpoint?
So this was a retrospective cohort study of patients undergoing hysterectomy for GYN malignancy at 4 participating centers across a very large academic hospital network. We had IRB approval for the study, and for the inclusion criteria, women who underwent hysterectomy with the final pathology confirming cancer were included in the study. For exclusion criteria, all women who underwent hysterectomy for other reasons were excluded, including if they had missing information, missing antibiotic regimens, anesthesia records, or operative records that were excluded from the study. The primary outcome was surgical site infection, and the primary independent variable of interest was prophylactic antibiotic regimen. Some of the other variables that were important to us that were included were reoperation within 30 days of surgery, hospital readmission, and antibiotics given for any other reason other than surgical site infection, and non-infectious wound complications within 8 weeks of surgery. So standard of care antibiotics in the study were defined as first or second generation cephalosporins, or clindamycin and gentamicin for patients with a penicillin allergy. And the comparison group, of course, was standard of care antibiotic plus metronidazole.
Excellent. So let's get into the results, and then we'll follow that up with questions from our fellows. So as Marina, you mentioned 4 hospital sites, 1,055 patients. Megan, what are some of the results highlights that you want our audience to take away?
So of our 1,144 patients who underwent hysterectomy, after applying the exclusion criteria, a total of 1,055 patients were included in the study sample. We found overall a surgical site infection rate of 3.2%, or 34 patients in our group. SSIs were independently found to be associated with pre-existing diabetes, smoking, and the antibiotic regimen. So in other words, patients who had a known diagnosis of diabetes, patients who were smokers, and patients were both more likely to develop infections, as were the patients who received the standard of care antibiotic regimen, as opposed to the regimen with the addition of flagella. The surgical site infection rates were 4.3% among those patients with the standard of care versus the 2.1% with the metronidazole. And then after adjusting for covariates, the addition of metronidazole was not found to be statistically significantly associated with the reduced risk of SSI with a confidence interval that did cross 1. So while there was evidence supporting an independent association between antibiotic regimen and surgical site infection rate, after we adjusted for the known covariates like open incision, smoking status, and diabetes, there wasn't a statistical difference in the infection rates with the addition of metronidazole. But I would just kind of note that our infection incidence, again, overall was relatively low. And, perhaps if we had a higher incidence, perhaps we might have borne out the relationship and statistical significance a little bit better.
Excellent. So we'll start now with the questions from our fellows, and I'll first turn to Marina. This question is about the type of patients that we operate on with regards to cancer versus benign. This question is from Mo Byrne. She's at Memorial Sloan Kettering in New York as well. And she asked, could you give us some background on how you think gynecologic cancer patients might differ from benign gynecology patients in terms of the bacterial flora and how this could influence their response to metronidazole?
So from the literature on the vaginal microbiome, although it's very preliminary, there is a reported change in the microbiome that occurs in the vagina and the endometrium and the rectal flora in women who have endometrial cancer. So different studies have reported correlations to different bacteria, and this may be related to development of endometrial cancer and ovarian cancer. For example, several studies have found that lactobacillus was depleted in patients with endometrial cancer as opposed to other conditions. So patients with endometrial cancer also have other causes that may change the microbiome, and this includes obesity and differences in estrogenization of the mucosa. Direct tumor involvement of the vagina may also change the microenvironment and the immune response. This change in the flora can certainly affect the changes in the microbiome and their overall response to antibiotics. So there is definitely potential need for additional antibiotic coverage and definitely more literature to be reviewed in this arena.
Great. We'll now turn over to Megan. This question comes from Joanne Nouveau in St. John's, Newfoundland, and she's interested about the surgical approach. Could the potential benefit of metronidazole be masked within the larger minimally invasive surgery cohort? And do you think stratified analysis by surgical approach might reveal a signal?
So Joni is absolutely right. The risk of infection is greater in an open approach, and that's been shown in other studies in the literature. So it is possible that having a larger open approach population in the cohort may have led to a different result, leading to a higher incidence of infection, and therefore a maybe more significant difference with the metronidazole use. In our study, we did have a larger minimally invasive cohort that led to lower infection rates in minimally invasive surgery. But, I think it's one of those things that will also sort of ebb and flow as the kind of population of your cancers that you're treating most often will change as well, and how we tend to approach them.
Now, Marina, this question comes from Masha Pervin, hospital in Münster, Germany. How do you explain the significant association of hemostatic agents used in surgical site infection? Is it justified to expand antibiotic prophylaxis, like give 3 days postoperatively if a hemostatic agent is used intraoperatively?
So that's a really great question as we think about all of this while we do our surgeries. From the literature, we do know that hemostatic agents use is associated with increase in predicated hospital readmissions. So hemostatic agents used in robotic laparoscopic hysterectomy have been shown to increase rates of blood transfusions, increased risk of pelvic abscesses, and increased reoperation risk. However, there's really no evidence to show that additional antibiotics will decrease those risks postoperatively. So infections due to hemostatic agents usually present later, 7 to 10 days after surgery. So whatever prophylactic antibiotic we're using should be covering the infection risk at that time. And there's really no evidence to continue additional antibiotics after surgery.
Interesting. Great. So, Megan, this next question comes from Paula Mateo here, actually at Houston Methodist. And she's asking, in the article, the authors state that among the postoperative factors analyzed were antibiotics administered for reasons other than surgical site infection. Why were these patients not excluded? Doesn't this introduce a confounding bias?
So Paul is right. This would have included a confounding bias, but it's just that it wasn't actually explicitly stated in the manuscript. We did exclude those patients who were receiving any sort of antibiotics for other reasons. Any patients with preoperative infection who are taking other antibiotics other than a confirmed SSI were excluded from our study. We just didn't explicitly state it in the manuscript.
Excellent. So this next question comes from Spain. Itziar Villagra, La Paz University Hospital. And Marina, I'll ask you, she says, in your study, surgical site infection was found to be independently associated with diabetes, smoking, and antibiotic regimen. Why was open incision included in the multivariate model despite not showing a significant association?
So given the small cohort of our study, only a few confounders could be chosen to be included in a multivariate model. And because outside literature generally has shown a difference between minimally invasive and open approaches and the risk of infection, this variable was controlled for in a model and it was chosen a priori. So it was chosen prior to running the study. Based on the existing literature, the variables that we believe generally do affect are those that you listed: diabetes, smoking, open versus laparoscopic incision, and the type of antibiotic regimen. So although on final results, open incision did not show significance in the risk of infection, it was included as part of the original multivariable model.
Okay. Megan, this question again from Paula Mateo. And another question about the analysis. She's asking, since women undergoing hysterectomy for cancer may require colorectal procedures and patients who underwent bowel resection were included, why didn't the authors analyze bowel resections as a variable in the adjusted model or perform a sensitivity analysis?
So in our cohort of 315 patients, only about 53 had concomitant bowel surgery, and 89 had debulking procedures. So this wasn't associated with a significant increase in surgical site infections on independent analysis. But bowel resections are absolutely an important factor that increases the risk of infection. It's just that in our cohort, the prevalence of bowel resections were overall pretty low. And so because we had lower numbers, we didn't include this in the multivariate model because the confidence intervals would be too wide.
Okay. And Megan, I'll stay with you for this next question. Comes from Mathilde Del from Toulouse in France, and she's asking about screening. Do you think that a systematic preoperative vaginal screening to identify and treat patients with abnormal bacterial flora could help reduce the risk of postoperative infections after hysterectomy?
I think this is a great question. So there is a lot of literature out there that addresses the prevalence of bacterial vaginosis and how that can play into postoperative infection risk. Bacterial vaginosis, or an overgrowth of that anaerobic bacterial vaginal flora, is relatively prevalent in the general population. Estimates range from about 19 to 29%. But it's often asymptomatic and not routinely tested for before a hysterectomy. We know that the administration of metronidazole is really targeting the treatment of bacterial vaginosis, particularly lactobacilli, but other anaerobic vaginal flora. And other research that kind of focus more on the cost-benefit ratio of treating that in a preoperative setting has shown that at least in the US, it would require a lot more patient visits and higher cost to the healthcare system in general to treat, diagnose, and identify that in the preoperative population, rather than kind of adding metronidazole, which is a relatively low cost and well-tolerated prophylaxis option in the prophylaxis setting.
Okay. Another question from Matilde Del. This one for Marina. What is the actual rate of metronidazole allergy? Are there any data on potential cross-reactivities with other treatments? And did you observe such cases in your study? And how do these reactions typically manifest? So several questions compounded into one question.
Sounds good. So allergic reaction to metronidazole is actually extremely rare, and there is absolutely no reported cross-reactivity with cephalosporins. So we did not observe any allergic reactions in our cohort, but it can manifest as skin-related reactions or systemic reactions. The most common could also include headache and nausea, but the impact of these is really masked by the anesthesia in the first 24 hours. And so generally all of these are very rare, including systemic reactions.
Okay, great to know. Tommy Moschini from University of Insubria in Italy. He's asking, and I'll turn to you, Megan. Since your results did not show a clinical benefit with the addition of metronidazole, do you consider going back to using the standard of care antibiotics alone? And given that diabetes emerged as a strong independent predictor of infection, which concrete strategies do you believe are most effective to reduce SSIs?
I'll answer the slightly easier those two questions first. So in terms of addressing diabetes and other known risk factors with kind of concrete strategies to minimize the risk, of course, when we're talking about taking patients to the operating room for treatment for cancer, we don't have the luxury of maybe significantly delaying their surgery to perfectly optimize their risk factors. But we do have some element of control in terms of managing their perioperative glucose, appropriately transferring their care to endocrinology or primary care to manage, glucose optimization a little bit more stringently, and changing insulin regimens or other anti-hyperglycemics preoperatively and perioperatively. But we know that our patients are generally high risk. There is a known association of diabetes, obesity, hypertension with endometrial cancer in particular, for example. And so acknowledging that we have patients who are at higher risk with underlying medical factors and at higher risk for infection, we will continue to use dual prophylaxis here because we also acknowledge, like I said before, that there are significant risks of morbidity and mortality for infection in these patients with cancer. Again, the delay in postoperative healing and adjuvant therapy, I think, is what really sets oncologic patients apart when we're talking about the risk for infection, as well as therapies that can reduce their ability to mount an immune response to any infection. So I think overall the risk benefit of providing a relatively well-tolerated and inexpensive medication compared to the, individual and system-wide cost of a high risk of infection is worth it, in our opinion, to continue practicing this. So even though we didn't really kind of prove it in our study, I think we both do still believe that if we had a higher incidence of infection, we could kind of bear out this relationship a little bit better.
Excellent. Itzi Villagra from Spain is asking, in your discussion, you mentioned a study showing that among patients who underwent hysterectomy for both benign and malignant conditions, cefazolin plus metronidazole was associated with a lower infection rate. Marina, why do you think your study's results differ from those other findings?
So one of the major differences between our study and other studies is that other studies had a larger cohort of patients overall, but our study had a larger cancer cohort. So additionally, many of the previous studies were done prior to full implementation of the ERAS protocol, and this may also significantly change their results. So although our study was negative, we do believe that we had a larger cohort of cancer patients. And if we even had more patients, we would have had significantly potentially different results with the dual prophylaxis.
Yeah, excellent point about the inclusion of ERAS as well as part of these implementations and these initiatives. Megan, I'll turn to you. This next question comes from Carlota Sabini, Ospedale San Rafael in Milan. And she's asking, based on factors such as patient comorbidities, tumor characteristics, or surgical approaches, there is still a specific subgroup of patients undergoing hysterectomy for gynecologic cancers for whom the addition of metronidazole is still suggested?
Yeah, I would argue that I would still recommend dual prophylaxis, including metronidazole, to all patients undergoing hysterectomy with gynecologic malignancies. Again, especially if we're talking about any sort of resource-limited settings, though, patients who we know have underlying medical conditions that put them at even greater risk for infection, like diabetes, obesity, a history of poor wound infection, any other reasons for immune compromise. But again, I think in general, we still do believe that patients would benefit from having dual prophylaxis in the setting of an oncologic hysterectomy.
Okay. Marina, Matteo Lovero from the Agostino Gemelli Hospital in Rome, I think, again, it's interested in what do you do in your practice. So he says, according to your study results, do you expect these findings to change your clinical practice, or do you think that the strong odds ratios, despite the non-significant p-values, mainly reflects an underpowered sample size, supporting the continuation of your current policy? And I think that Megan addressed a little bit about this, but yeah, I'd love to hear your thoughts.
Thank you. This is a really important question because in our area in New York, we treat very sick patients who are generally high risk for infection. And these include severe obesity, patients complicated with diabetes, and of course, cancer. So we do believe that our study is underpowered to yield some of these complete results, but we strongly believe that continuing dual prophylaxis for GYN oncology patients, particularly in our type of high-risk practice, is still really important.
Yeah, excellent point. And Megan, another question from Matteo, and this is a question that often comes up in our ERAS meetings. Given the low frequency of surgical site infections, a randomized clinical trial will likely require a very large sample size. Do you think such a trial is feasible in the exclusive gynecologic oncology setting, or would it be more realistic to base future recommendations on multi-center retrospective series and eventually on a GYN oncology specific meta-analysis?
It's a great question. We always talk about retrospective studies as truly the gold standard. As randomized clinical trials is the gold standard. But I think to acquire that number within a single institution would be very difficult due to many confounding factors. And I think specifically within the oncologic population, we found that the best way to kind of yield our data was doing this, again, sort of capitalizing on a moment where we had a policy change within our institution. But, you know, with the resources available, a multi-center approach would probably yield the cleanest data.
Excellent. So couple more questions. Marina, I'll turn to you. Johnny Novo again. Asking, given your results and the push to limit antibiotic exposure and the low absolute infection rate you observed, 3.2%, how should clinicians balance the potential benefit of adding metronidazole against antimicrobial stewardship goals and the risk of resistance in the era of ERAS protocols?
So this is a really important question, and resistant rates vary widely by the region of where the flagell is being administered and also the type of bacteria that you are treating with the flagell. So given the high-risk population that we're taking care of, as we mentioned before, obesity, high risk of diabetes, abdominal wound patients, and other downstream concerns for these postoperative patients, we still would recommend dual prophylaxis because we don't want to delay their next steps, which includes chemotherapy for their cancer. However, of course, the resistance rates are really important to address and have to be weighed between for that patient between the risks and the benefits. Excellent.
So Megan, as a last question to you, in tradition now in our podcast, this question comes from AI. When AI actually read your manuscript, it came up with this question in anticipation of this podcast. And it says, given the retrospective design and the simultaneous institutional policy change, in other words, introducing both metronidazole and chlorhexidine vaginal prep, Can the authors truly attribute any observed infection rate differences to metronidazole, or does this design confound antibiotic efficacy with concurrent antiseptic and ERAS protocol changes?
I have to say, I'm increasingly impressed by the complexity of analysis that AI is able to come up with. But this is a great question. So at our institution, we did capitalize on this protocol change. And so the change in antibiotics that we looked at in our retrospective study did also coincide with a change in our vaginal prep from iodine to chlorhexidine. And so the benefit to us in kind of constructing our study was that this helped us ensure an unbiased distribution of antibiotic prophylaxis between the two cohorts and enabled us to kind of capture a window of time where few other variables might have changed and get this done a bit more quickly than a randomized trial. But when we looked at the choice of PrEP as an independent variable in relation to SSI rates, we found that the choice of PrEP was not independently associated with risk of infection. So I don't think that it ultimately had a significant confounding effect on our results.
Excellent. I think AI will be very pleased with that answer as well. So I want to thank you both so much again for taking the time to discuss this with us, for actually doing this study. And then, of course, obviously, congratulations to you and all of the co-authors who participated in this project. And again, for your contribution to the field of gynecologic oncology by providing this really important information.
Thank you so much for having us, and thank you to all of the fellows who contributed their thoughtful questions. We really appreciate it.
Thank you. We really enjoyed working with you on this.